Welcome to the License to Lead podcast. I'm Patty Fay. This podcast is for physicians or anyone who thinks healthcare needs a transformation led by physicians. License to Lead means that physicians are charged with and must be in charge of guiding the vision, the standards, and the culture of healthcare systems. If you want to join in the conversation or learn more about activating physician leadership, go to license2leadpodcast.com, where you can send me an email or even leave me a voice message. I'd love to hear from you. Thank you for listening to my inaugural podcast on physician leadership. License to Lead is for all physicians, physician leaders, as well as those doctors who have not yet embraced their leadership roles. And this podcast is for anyone who wants our medical care and our healthcare organizations to function more effectively, because excellent physician leadership is our best bet for improving those systems. There are some who say doctors are not well suited to leadership roles. I have a different perspective. By the very nature of the long, comprehensive on-ramp into medicine, by the nature of medical training, not despite it, doctors are uniquely positioned to lead healthcare. And yes, I do realize that this flies in the face of the often repeated old saws about the arrogant lone wolf doctor who just doesn't get the business stuff and who's not a team player. And what do I say to that? Prove it, because evidence points to the contrary. Healthcare systems are likely to have better outcomes when a physician is at the helm. While the License to Lead podcast is focused on physician leadership, because that's my specific lens, the converging point of the work I do and all the topics that I teach and write about is organizational culture. In medicine, a healthy organizational culture translates to high-performing individuals at all levels and in all roles, working as a team and creating excellent outcomes for patients. A healthy organizational culture translates to fulfilling careers for nurses, technicians, physicians, clerks, administrators. In the world of healthcare, it's not possible to have an excellent culture without close attention to the physician career, at least the high-performing physician's career. And my premise is that physician leadership at the top is required. Today's podcast focuses on 4 issues that I think are foundational as I launch into my perspective on physician leadership. First, the physician as professional and what are the implications and obligations. Second, physician autonomy. This one is in bold and all caps. Third, the corporate practice of medicine doctrine. And then finally, fourth, a certain intriguing disdain for physicians among some administrators that is often tolerated in healthcare organizations. Before I dive into those 4 areas, who am I and how do I come by all my opinions? I'm an internal medicine physician. I did my residency training in Arizona, and I practiced for a couple of years in Southern California, in San Diego. Then we moved to Colorado, where I practiced internal medicine. Currently, I'm the owner of a company, Fay Consulting. My partner, Lynn Elliott, and I are leadership coaches. We work with leadership teams, and we conduct leadership programs. We run our programs on-site in academic institutions, healthcare systems, hospital associations, and other settings around the country, and even a wee dram internationally. About 75% of the work we do with leadership coaching and leadership development is with physician leaders. So, how did an internal medicine physician end up with this kind of a career? Well, it started with a disruptive physician, me. For many years, I practiced internal medicine in Colorado with Kaiser Permanente, fulfilling those 4 A's of a successful physician: available, affable, affordable, and able. And given half a chance, I was always eager to add fun or funny to the equation. So with the slightest encouragement, I'd aim for 4 A's and an F. But I was basically a good doobie, worked hard, tried to contribute, and got along great with the nurses, techs, clerks, administrators, colleagues, and patients. I worked with outstanding staff and many excellent managers. In fact, those excellent managers and administrators I worked with helped shape my opinions about the other end of the spectrum, the administrators who harm the organizational culture. More on that later. Early on, my only administrative role was helping with recruiting and interviewing. At one point, my chief had asked me to help with the physician's schedule, but I told him I'd rather stick needles in my eyes than deal with that. But I also told him I was very interested in helping to interview and choose the incoming talent who I work alongside, basically the people I'm married to at work. Now, that's important. So, nothing out of the ordinary early in my career. I was low profile. Then, the leaders of the organization got ramped up to install some sweeping changes, which had a negative effect on physician career and physician autonomy. And up to that point, I hadn't paid much attention to the larger organization. But suddenly, our medical offices and the hospital where we practiced were swarming with blue-suited consultants. The heavy-handed language and initiatives coming from the top reflected a belief among the offices of Mahogany Row, as the C-suite was called, that the people of the organization, and most particularly the doctors of the organization, were the problem. But what I noticed was that it was the people around me in the medical offices whose values and leadership I admired and trusted, not so much the physicians or administrators who had floated to the top of the organization. And I didn't think physicians were the problem. I was pretty convinced they were the solution. Then, one of the excellent internists I had helped to recruit and hire resigned. And he was incredulous that I intended to stay. He said, "Patty, what are you doing? Honestly, you've got plenty of options. Get out of here." The culture had become oppressive and punitive. I didn't like the attitude or the tactics of the organizational leaders, but I loved my colleagues and local administrators and nursing staff and patients. I appreciated the KP model. My medical group, on paper anyway, was a physician-led organization. I believed it was an ethical model of healthcare. So I figured I had nothing to lose. Instead of following my colleague out the door, I decided I'd get involved. I'd weigh in on the proposed changes. I'd have a voice. And then if nothing changed, I could always bail out later. So how do I know I was disruptive? One clue was the fact that I was invited with 2 other physicians to a formal evening meeting with the president of the health plan, the president of the medical group, the chair of the board, the medical group attorney, and an array of others. I called it the spanking. We were reprimanded because we'd rallied the docs around some alternative proposals and revisions to the plans the leaders were rolling out. Rolling out, isn't that a humdinger of a phrase? In an organizational context, when something is rolled out, it never evokes the image of a red carpet, but much more likely the image of a steamroller, noisy, smelly, intractable, and indiscriminate. I may have to do an entire podcast on the words that suck the energy out of people. Of course, provider would be at the top of the list. Anyhow, the bigwigs didn't overtly threaten our careers. Up to that point, we'd been high-performing, non-complaining doctors with boatloads of devoted patients. It was awkward for the stern people sitting around the board table that evening to deliver just the right dose of ominous without making things worse or adding us to the list of physicians jumping ship. I was disgusted with the whole intimidation effort, the dim view of humanity I was perceiving, the reliance, not on physician experience and input, but on freshly minted, healthcare clueless MBAs from a well-known national consulting company. Let's call it MIC Consulting. So soon thereafter, I ran for the board of directors on an anti-administration platform. Then, as a board member, I helped select the new executive medical director, Jack Cochran. He didn't waste a minute showing the old team the door and inviting in new physician executives, including me. I was in charge of creating a strategic HR department. In other words, my job was to put in place the pieces needed to create a healthy organizational culture. A Stanford leadership guru, Jeffrey Pfeffer, wrote a book called The Human Equation. It was one of my favorite references when I was on the board of directors and trying to figure out the diagnosis and treatment of our struggling organization. As soon as I was at the VP level, my title was Associate Medical Director, the book became my Bible. I clutched it in my newly deemed executive hands as I took on the strategic HR role. I signed up for a 1-week executive HR course at Stanford, and I must have been quite attentive because that 1-week course was the extent of my formal HR education. I emphasize the word formal because, like anyone who's fascinated by their work, I learned every day. I couldn't get enough of the topic of organizational culture. I was thrilled to see the real effects on careers and healthcare outcomes. In subsequent podcasts, I'll zero in on the nuts and bolts of the leadership, mentoring, recruiting, recognition, and performance management programs we put in place. But for now, I'll say we had a dramatic transformation in outcomes, both medical group and, as a result, The health plan and insurance arm of the organization also saw remarkably improved business outcomes, and it happened within just a few years. The physician satisfaction survey improvements were remarkable within 18 months, and turnover of great docs plummeted. So we were able to retain great doctors, and suddenly we could recruit great doctors again. Then what followed was excellent quality results and a not so surprising change in reputation in the community. And just to make sure everyone was paying attention, our financial results went from in the red to the best ever. Remember Jeffrey Pfeffer, the guy who wrote my favorite HR book? He wrote about the Colorado transformation in Stanford's 2.0 business journal. You can check it out on my podcast page at license2leadpodcast.com. But let me be clear, physician leadership itself is not a magic bullet, at least not based on my anecdote, right? After all, we replaced physician leaders who, along with their health plan partners, had presided over the previous poor results. Physician leadership is necessary but not sufficient. Any old random doc who wants to grab the reins will not do the trick when it comes to creating the outstanding results needed in healthcare. And as is true in any profession and with any type of organization, the more someone wants to grab the reins and be the boss of you and me, the more suspect they are. In my License to Lead podcast number 2, I'll talk more about why physician leadership is necessary and what leadership characteristics make a difference. Let's get into the innards of the podcast. Part 1, medicine as a profession. What is the significance of the term professional? It used to be more narrowly defined as a person engaged in one of the learned professions. The 5 traditional professions alphabetically are architecture, clergy, engineering, law, and medicine. Professions are characterized by a long on-ramp of broad conceptual or abstract education. Organic chemistry, histology, and a year or so with a cadaver. In medical school academics, everyone learns everything, so the passage into the profession is comprehensive. Doctors spend about a decade, typically our 20s, first in undergrad, competing academically in hard classes, while doing volunteer work in order to position ourselves to do well on the MCAT and with the medical school application process. Lots of our college peers drop their aspirations to go to medical school after a big dose of organic chemistry or calculus, or when their GPAs become the writing on the wall. Some choose a less daunting clinical field or switch gears completely. And they're often nicely rewarded by making a good living as a physical therapist or a realtor, while their medical student friends sacrifice all of their 20s to an unbelievably rigorous academic load, a bona fide depressing existence for many, and catastrophic debt. The on-ramp is long and it's steep. After 4 or 5 years of undergrad, 4 years of medical school, and 3 to 7 years of specialty training, we know a little and sometimes quite a bit about every field and most healthcare or medical settings. This broad and deep understanding of the field is characteristic of the traditional professions, but it is absolutely exemplified by medicine. This deep immersion into the field is an important element that I'll cover in my next podcast when I talk about tacit knowledge and technical expertise, 2 critical ingredients of excellent leadership. Other characteristics of the traditional professions are self-regulation, a code of ethics, prestige, autonomy, and a special obligation to serve the interests of the public or client, or in our case, the patients. The term profession is used in so many ways now to describe a firm's legal structure, for instance, or to describe various occupations. And also the term is used indiscriminately in advertising, like professional sod and turf. To me, a relevant way of distinguishing the traditional professions such as medicine and law is the buck stops here. All the knowledge about the field is found within the profession. We don't have anywhere else to turn. If I don't know what to make of my patient's cardiac symptoms and EKG, I call my cardiology colleague. If she's at an impasse, she calls the interventional cardiologist, who might turn to the cardiac surgeon, or to the endocrinologist, or to the psychiatrist. The profession itself contains the full scope of knowledge and practice. The nurse or advanced practice clinician are professionals. I wouldn't deny them that term of respect, But these professionals turn to physicians for orders or for a level of diagnosis or intervention or treatment or surgery that nurses and advanced practice clinicians or respiratory therapists or physical therapists are not trained or licensed to provide. The PT looks to the physiatrist or family medicine physician for additional diagnostic or treatment options. Optometrists reach the edge of their scope of practice and they turn to the ophthalmologists. My point in talking about the traditional professions, the buck stops here professions, such as law, architecture, engineering, is that members of the profession lead those organizations that do the work of those professionals. In the other traditional professions, this is the rule, with a few exceptions. So in the majority of even the largest and most complex U.S. and global engineering firms with multiple business units and thousands of employees, the CEO is an engineer. Lawyers lead law firms in the overwhelming majority of cases. It's headline-worthy in the law world when that's not the case. You can check it out. You can Google non-lawyer leading law firm and see the headlines and read about the kerfuffles that arise. In contrast, in medicine, physician CEOs are the exception and lead a small minority of hospitals and healthcare systems. We've abdicated leadership of our profession. We've abdicated leadership of the settings that rely on the physician's education and the physician's license in order to take care of patients, in order to keep their doors open. This creates a lack of clarity about leadership and authority. A lack of alignment between the top leaders and the physicians contributes to many of the crazy-making and harmful situations in medicine that have degraded patient care and degraded physician career and degraded healthcare organizational cultures. How? Henry Mintzberg, in his 2017 book, Managing the Myths of Healthcare, describes remote control management, which is detached from the core business of an organization, but that remote control management is determined to control the core business. Mintzberg says, quote, "It works badly, even in business where it came from. In healthcare, it reorganizes relentlessly, measures like mad, favors competition where there is the need for cooperation, and pretends that this calling should be managed like a business. The more of this we get, the more dysfunctional healthcare becomes." Close quote. In License to Lead podcast number 3, I'll specifically address managerialism and the ideology of business school education that has infected and I think harmed healthcare organizations. The highest profile iceberg sinking the medical profession and sinking medical professionals is an electronic so-called medical record that requires physicians to do double duty every day, spending hours as data entry clerks. A study in the November 2019 Mayo Clinic proceedings again demonstrates the harm perpetrated when the EMR by design serves administrative and financial ends as its primary function and creates barriers for the physician in the medical care of patients. Here are the author's conclusions. Quote, "The usability of current EHR systems received a grade of F by physician users when evaluated using a standardized metric of technology usability. A strong dose-response relationship between EHR usability and the odds of burnout was observed." Close quote. Well, that last sentence is certainly sterile and business-like. Let me help a little by rephrasing that one. How about this? Quote, "There was a strong correlation between the expensive, underperforming electronic medical record, which has a user experience score of F, and the risk of physicians becoming ill, incurring harm to their careers and personal lives, and being at increased risk of death by suicide." Close quote. Ah, shoot, I'm sorry. That was dramatic. But what I'm really sorry about is it was true. So this tool, ostensibly serving the physician-patient relationship and patient care, but designed to serve administrative needs, exploits the professional work ethic of the doctor and the apparent unlimited expandability of the doctor's day. When physicians don't lead, priorities like bedside nursing are seen as overhead rather than the critical linchpin role that allows excellent quality and service for patients and families. When administrators don't fully understand the clinical world, when they are remote control managers, then nurses get rolled up in reductions in force, along with administrative staff and cafeteria workers. When the leaders don't really know the core business, when they don't really understand the profession, there's a much greater likelihood of such penny-wise and pound-foolish efforts that defy quality, but provide quick fixes for a failing bottom line. Commoditization of people and professions means the OB-GYN doc, the family medicine doc, and the internist are lumped into something called primary care. Physicians, clinicians, technicians become providers, the better for monitoring, counting, and standardizing schedules, rules, expectations, and authority. When everyone is a provider, decision-making is blurred. There is resentment and jockeying for position that creates fertile ground for the most dysfunctional personalities to thrive. And lines of authority, rather than providing much-needed clarity in healthcare, become points of contention and competition. The best care for patients is served by a team that is extraordinarily collaborative and aligned, where toxic behavior is not allowed from anyone. Healthcare teams have to function with the yin-yang of trust and collaboration on the one hand and clear lines of authority on the other. For those listening and shaking their heads, convinced I'm an apologist for tyrannical behavior by docs, nope, au contraire. Much more on that when I talk about recruiting and selection of physicians and performance management of physicians. If you just can't wait for how I really feel about toxic docs and toxic others, go on ahead and read my article on how not to hire a narcissist. There's a link on my podcast page at license2leadpodcast.com. So in medicine, we have an unfortunate exception among those entities we call the traditional professions, in that we have given over leadership of institutions in which we work to people who are not in the medical profession and may not even be in a healthcare field. This is misguided and reversible, and fixing it depends on people who care about healthcare outcomes and people who care about patients, leaders in our communities and on hospital boards noticing what's happened. There's an entire academic industry that has sprouted alongside the profession of medicine in recent years. The MHA, or Master in Healthcare Administration programs, have proliferated. They offer a tantalizing promise to those who want to manage hospitals and systems. Much more in my third License to Lead podcast regarding the Masters in Business Administration, or MBA, and the closely related Masters in Healthcare Administration, or MHA. What do we know about these business degrees, and what do we know about the associated outcomes? Part 2. Autonomy. Autonomy is an underlying theme of the License to Lead podcast. As I said earlier, this is the topic that deserves all caps and bold font. Autonomy is central to the definition of the traditional professions. It's understood that those with whom the buck stops require control over their work. Professional autonomy is central to the relationship between a physician and patient. Statutes to ban the corporate practice of medicine were put in place in the first place to assure physician autonomy. I'll talk about those statutes in a minute here. Reinstating physician leadership of the medical profession in the settings where physicians work, which is the motivation for this podcast, is to capture the advantages that accrue to patients and to healthcare delivery when physicians are able to assert their professional autonomy on behalf of patients and the community. Physicians are not able to comply with that professional obligation when they're not the organizational decision makers. And no, the insertion of a CMO to signal physician leadership is not what I'm talking about. The CMO is often in a special limbo with responsibility without commensurate authority, the plight of most doctors. But the CMO also is beholden to the administrative team, which, if not physician-led, doesn't share the professional obligations of the physicians. This is not an easy spot to be in. So how do we know autonomy is as big a deal as I'm making it out to be? How do we know it's not just code for letting docs tyrannize the workplace and intimidate all the administrators? How do we know there is any real kind of significant issue related to loss of autonomy in our practices, hospitals, and healthcare systems? Well, I've already discussed it. One word: burnout. And yes, sticklers, it is one word. Do we need any more neon to highlight this issue than a 44% burnout rate among physicians? At its core, burnout is caused by an autonomy deficit. It is not for lack of a shiny wellness program, which was probably ushered in by the same opportunistic consultants that helped create and roll out the current misguided and so-called efficiencies. And no, it's not the fault of doctors who have a resilience deficit. Are you kidding me? Docs with a lack of resilience? What? I don't think so. Despair in medicine is directly linked to a loss of our professional autonomy. Every time I hear about a new wellness program to address burnout, I cringe. Who's coming up with this stuff? The physician who is doing his late evening shift as a billing and coding clerk is supposed to find time to attend meetings on how he can take better care of himself? I can just see the family doc having to postpone her 1 or 2 hours of data entry at home, miss dinner again with the family, and attend a meditation, stress reduction, and resilience training. I mean, what's a metaphor for that? Putting leeches on a patient to cure anemia. Anyway, I'll veer back off my wellness, i.e. blame the unwell doctor rant, and climb back onto the autonomy issue. Loss of autonomy means accountability without authority. Authority lies elsewhere, but the physician has an unrelieved duty to the patient. In other words, unrelenting accountability and responsibility for outcomes in the face of inability to determine or sometimes to even affect schedules, systems, personnel, software, and workflow, including the documentation of care. This is where I'd like physicians and others to notice what's happened to our profession. Somehow physicians have become workhorses to others who dictate decisions about our practices and patient flow and number and type of support staff and work assignments of the staff. The physician whose skill, medical degree, and services generate the revenue is subservient to the management decisions of others who do not share the physician's professional ethics and obligations. We've arrived at a state where someone, clearly with a short-termism mindset, has decided that a criminal number of computer clicks is the right use of a physician's time. There's a lot of hand-wringing going on by pundits and pontificators of various stripes about all the woes of healthcare and the horrendous spiraling costs. You can read headlines like the October New York Times article stating that 20 to 25% of U.S. healthcare spending is wasteful. And the largest source of that waste is the $266 billion a year spent in administrative costs. Consider that information. A quarter of the money spent is waste, and the biggest chunk of that waste is attributable to administrative costs. Link that information to the Bureau of Labor Statistics chart. It's pretty dramatic, documenting a 3,000% increase in the number of administrators from 1970 to 2009, which parallels the 2,500% increase in healthcare costs. Over that same period from 1970 to 2009, when the number of administrators went up over 3,000%, the growth in the number of physicians grew 150%. If you haven't seen this Bureau of Labor Statistics chart, it's included in an online article I wrote. You can see the link at license2leadpodcast.com or just Google Kevin MD Patty Fay and my article will pop right up. It's titled Why Physicians Must Lead. But visualize this, a 3,000% increase in administrators, 2,500% increase in healthcare costs, and the 20 to 25% chunk of those healthcare costs are deemed waste, the largest chunk of which is attributed to administrative costs. According to JAMA, our healthcare outcomes in the U.S. are 11th out of 11 high-income countries, and our life expectancy was the lowest, and infant mortality the highest here in the U.S. It's got to be time to at least investigate whether the obscene growth in the number of administrators paralleling the growth in U.S. healthcare spending per capita is an etiology, not a result, as some might claim, of the many distinctly dysfunctional issues in healthcare. It's time to at least investigate whether current approaches to management in hospitals and healthcare systems contribute to poorer healthcare outcomes. And here's the connection to autonomy. For physicians and their teams to deliver optimal care, physicians have to be central to devising and leading the solutions that actually make sense for patients and make sense within the context of medicine. Swarms of non-physician administrators beget more administrators as they create and attempt to solve issues in an industry they don't and can't fully understand, as they prioritize efficiencies that attempt to turn professionals into commodities, as they elevate short-term business goals and margin in not-for-profits and for-profits above the healthcare outcomes of patients in the community. Here's the key. Physicians must have autonomy and authority equal to their level of accountability. If a system requires the use of a medical license in order to do its work, the professionals holding those licenses must have the latitude and authority and autonomy to make sure that they can carry out their work. It's not going to happen until physicians lead medicine, healthcare, and healthcare systems. Part 3, Corporate Practice of Medicine. You've probably heard of the corporate practice of medicine doctrine. This refers to state regulations that ban corporations or individuals who are not physicians from directing a physician's practice. The undisputed purpose of the ban is the protection of the patient. How so? Well, here comes the link to autonomy. These statutes recognize that a corporate entity that is not physician-led or a person who is not a physician would not share the same professional obligations to the patient. In fact, the obligation could be to shareholders or to their own career trajectory or to increase personal or corporate profits. So legislators around the country deemed that the autonomy of the physician in caring for patients must be subject to law. In 2015, attorney Stuart Silverman wrote a 23-page health law and policy brief about the corporate practice of medicine. Here's a sentence from his introduction. Quote, "The corporate practice prohibition is rooted in the perceived evils that corporations and lay people motivated by profit will exert control over physicians, tainting the fiduciary role of the physicians vis-a-vis patient and compromising the medical judgments of physicians." Close quote. The intent of the laws originally was that physicians would only be led by other physicians and that the only non-professional person who should be able to tell the professional what to do is the client or patient. These statutes have been subject to endless challenge state by state as various lobbyists have sought to dismantle the language. Some states don't have any language addressing the corporate practice of medicine. But my point here is that there have been many legal battles seeking to mandate physician autonomy based on a concern about protecting patients. There's big-time circumvention of the intent of these statutes in healthcare organizations, and we should all pay attention. Community members, hospital board members, members of chambers of commerce, and anyone who assumes their physician has the autonomy to do the right thing on behalf of patients. You all have an interest in examining whether this is a reality in your local teaching institutions, hospitals, HMOs, wherever medical care is delivered. Many physicians are exhausted and numb to the degradation of physician autonomy. Physicians are worn down by the extraordinary barriers to simply carrying out the work of patient care. Now notice, I didn't say the physicians are worn down by the work of patient care because no, that's not the case. Physicians have an enormous capacity for work. They are worn down by the extraordinary barriers to carrying out the work of patient care. A May 2010 article in Business Law and Governance states, the basic premise is that there's a divided loyalty between the interests of a corporation and the needs of a patient. Simply stated, the patient's need for treatment and care and the physician's related judgment conflicts with the corporation's interest in maximizing its profits and reducing its costs. Please notice if or how your practice and your relationships with patients and your care for patients are influenced by those who don't have the same ethical and professional obligations as you. How would your practice be different if high-performing physicians you respect, were at the top of your organization making the decisions? Now, as an aside, I recognize you could be in an organization that is run by a physician, but the physician doesn't meet these two qualifications. He or she is neither high-performing or respected. That situation is an important part of a later podcast focused on identifying and promoting excellent leaders. But back to the corporate practice of medicine, to rub salt into the wound of lost autonomy and the implications for patients and for the priorities of healthcare organizations, there's another important factor related to the corporate practice of medicine. If, as a physician, you tolerate someone else making patient care decisions, or even embrace it, for instance, by having a management company run your practice and make decisions that affect patients, you are putting your medical license at risk. Depending on your state laws, you can be dinged by your medical board for violating the statutes that ban the corporate practice of medicine. You can get in trouble if you let others direct your patient's care. There's a California Medical Board presentation with a video I would love for every single one of my listeners to watch. I put a link on the license2lead podcast.com site, or if you just Google California Medical Board Corporate Practice of Medicine video, up it'll pop. And since the intent of this California Medical Board video was to educate physicians to pay attention and not permit non-physicians to direct medical care, I'm curious if any California physicians who are listening actually saw this video. The video is a presentation to the California Medical Board given by 2 attorneys and an analyst, and it's an explicit description of the issue that underpins all of these corporate practice of medicine statutes. When the attorneys talk about what physicians should not permit, they included elements of patient care like medication choices, control and ownership of the medical record, scheduling of patients, and the hiring of staff. Allow me to say, yikes. When you think about how complex our healthcare environment is, it would make the most sense if there was comprehensive and totally accessible information available about exactly what is written down regarding the legal ins and outs of physician autonomy and decision making. A video like the California Medical Board video should be required viewing among physicians with relevant variations for each state. But here's a catch-22. We're too busy and too exhausted from complying with the mandates of institutions to notice the jeopardy that we and our profession are in by complying with the mandates of institutions that are not physician-led. One of the first things I did when I joined the executive team was take the exact language of the Medical Services Agreement on the road to all the physicians. The Medical Services Agreement was a detailed description of the authority and accountability of the physicians versus the health plan and insurance company. However your workplace and practice is structured will also be spelled out legally, and you can bet it will have language that on paper is compliant with the intent of corporate practice of medicine statutes. What I found was that the legal language stated physicians were in charge of the delivery of care and of all aspects of the clinical setting, which includes supervising the staff, approving how the services are advertised, and of course, making the clinical decisions. But leaders in the organization weren't aware of this language or the implications. At that time, one of the big issues in our organizational culture was that the physicians had a sense of hopelessness about even being able to influence, much less direct, their own practice or their staff. The docs would say, but they don't report to me. And the staff would say, I don't report to the doctors. When in fact, by legal agreement, physicians were the leaders of their teams and their staff and were the decision makers regarding patients and healthcare. What is written down is often obscured with bureaucratic language or legalese, or made very difficult to access, when what should happen, the right thing to do, would be to wallpaper the docs' offices with the language. It's our medical license, our patient relationships and patient care, our careers, all at stake. If the institutions that seek to employ us, and in increasing numbers of cases do employ us, are not inclined toward transparency, we have to go after it. So please get your hands on all the language that describes your authority and your autonomy within whatever organization you're in. Ask for it before you join an organization. Discuss it with your attorney, not the institution's attorney. I gotta say, there is nothing hard about this stuff. The concepts aren't hard. I mean, it's not organic chemistry or liver metabolism, for crying out loud. The language is often BS-y gobbledygook that is, and I say this with dramatic understatement, unnecessarily convoluted. So the concepts are straightforward, but I'm pretty sure the language is designed to make our eyes glaze over. Don't put up with that. In my executive HR role, I worked with our wonderful contracted attorney to get rid of unintelligible legalese. Whether it was policy language or employment contracts or even severance agreements, we whacked away at the legal gibberish and installed readable and respectful language. A future podcast will have to focus on the need for corporate attorneys and, for that matter, the accountants and CFOs in organizations to realize who their customers are and create language and reports that clarify rather than obscure. Okay, that was another tangent. Okay, so understand the corporate practice of medicine statutes in your state and compare your own employment or contractual language to those statutes. Make sure your actual practice, not just the written language, is consistent with the statutes. Because, as you will find out when you watch the California Medical Board video presentation, it's the actual workflows and decision-making, not an organization's written policy, that determines whether your organization is compliant or whether you are compliant. But the bottom line here, the most important thing is to understand the policies in your workplace and the exact language that addresses your responsibilities and your authority as a physician. Part 4, Antipathy for Physicians. I remember heading in to round on patients one morning, and I was in a hallway that connected the parking structure to the medical offices and hospital. An administrator stopped me to ask me about my intention to run for the board of directors. I can still smell the bacon wafting up from the cafeteria below. In fact, that olfactory link might explain why this mundane interaction sticks with me. Anyway, the administrator stared up at me, which, now that I think about it, is in itself memorable, because I'm not exactly a long drink of water. She explained to me that doctors should stay in their exam rooms, just see the patients like they're supposed to, and leave management to people who actually know what they're doing. Presumably, she meant herself. As I've mentioned, one reason for getting involved in the first place for me was the dim view of humanity, and particularly the dim view of doctors, that I had noticed in some managers, particularly those at the top of the organization. It struck me that this middle manager felt justified in demeaning physicians, not only their management potential, but her reference to docs staying in their exam rooms registered something else, doctors as widgets. Widgets. Not professionals with knowledge and obligations that are very relevant to the bigger strategic picture. It seemed clear that her management culture, which was my management culture, permitted a limited and disdainful view of physicians. A view that seemed to reverse the authority laid out in the organization's founding documents and in the medical services agreement that I referenced earlier. Now, obviously, that wasn't my first exposure. It wasn't even a significant example of disdain directed at physicians. During training, many physicians have to become adept at navigating unfriendly environments. But my bacon anecdote helped me notice with concern that it's not at all unusual for people to end up in healthcare administrative positions who don't respect doctors or who resent doctors. I think that's disconcerting, isn't it? And what's even more interesting is that many of the physicians listening right now, and certainly all of the experienced physician leaders, are probably saying, "Thank you, Captain Obvious," because many physician leaders are so used to navigating around and through administrators who take a particularly dim view of doctors that it ends up seeming normal, but it's not normal. There's nothing normal about professionals working in a culture which is, in many cases, number one, led by people who have little experience in the field they're leading, and number two, led by people who have a marginally disguised disrespect for the professionals who have the ultimate responsibility for the clients, or in our case, the patients. Of course, the majority of people in administrative positions in hospitals and healthcare organizations partner wonderfully with physicians and others, and they care deeply about their work. The majority of administrators I know and have worked with are fine and caring people. They become victims of the chip on the shoulder administrator too. In my experience, the administrators who are resentful of physicians create a negative work environment for everyone around them. And sadly, or maybe predictably, they are inordinately upwardly mobile. Not to be pessimistic, but we all have to exert a lot of energy in any organization to keep the least suitable people from moving up and up. If your organization is one with acrimonious relationships between physicians and administrators, your efforts to eliminate or even just to describe problems or barriers to patient care will not be welcome. Your concerns about the call center or the inadequate surgical trays or the overwhelming problems with the electronic medical record will be chalked up to yet another physician who just won't get on board. Oops, there's another one, getting on board. Now that's a top candidate for the list of words that deplete energy. Why are administrators in hospitals, clinics, or health systems who have a thinly veiled resentment towards docs even hired, promoted, tolerated? Why is this a thing? I think this misalignment affects careers, costs, and outcomes in healthcare. So for decades, I've said, physicians are not overworked. They're over-frustrated, stymied. Their autonomy to act on their professional obligations to patients is blocked. And studies have confirmed exactly that. Barriers to caring for patients are the greatest source of dissatisfaction and burnout for physicians. This podcast is ultimately in service of creating a supportive, engaging culture where everyone is focused on taking great care of patients. Like I mentioned early in the podcast, just before matriculating onto the board of directors and onto the executive team, some people saw me as a disruptive physician. But I'm like most physicians. I can work my ass off. I love having fantastic relationships with nurses and technicians and APCs and administrators at every level. And my Art of Medicine scores were right up there with some of the highest patient satisfaction scores in our group. When I pushed back against the dim view of doctors administration, the impetus for me was to take care of high performers. Every time a great physician would leave, I took it personally. Because excellent, high-performing physicians create a wonderful work climate. They attract other high performers and high performance in every role, and great results for patients follow. So what are some action steps based on today's topics? I have 5 for you to consider. 1, please do watch the California Medical Board video regarding the corporate practice of medicine. Go to my site for the link or Google California Medical Board Corporate Practice of Medicine video. Number 2, find out what's written down. What is your employment or contract language regarding physician accountability and authority? I don't necessarily mean your own personal contract, though that's critically important. But I mean, what do the organizational bylaws and other legal language have to say about the authority and accountability of physicians? 3, support excellent leadership wherever it is. Honor and help excellent physician leaders and excellent non-physician administrators. And please support the very best physicians to take on leadership positions. Ditch any verbal tics you've picked up maligning leadership or describing docs who take on leadership roles as going to the dark side. Encourage your colleagues to dump the negative banter too. We're shooting ourselves in the foot by not recognizing the necessity to lead. Support the best among you to take on leadership roles and be a great follower until your own leadership opportunity comes along, and then take it. 4, don't nod, smile, or stay silent when administrators of any background, doctor or not, make disparaging comments about physicians. What a crock. I mean, look at the kind, often brilliant, outstanding humans you know who are physicians and who care selflessly for their patients and their teams. Physicians are a remarkable swath of humanity. And if your organization is chock full of toxic physicians, to steal Jordan Peele's movie title, get out. Or better yet, as an informal or formal leader, attempt to address the disruptive docs or the toxic physicians. As you might imagine, I would distinguish between the terms disruptive and toxic. Just like a weed is a flower out of place, a disruptive physician might be an excellent leader in a dysfunctional culture. But either way, disruptive or toxic, help them out or help them out. And then number 5, please stop using the word provider. All right, so what's coming up next? Next in License to Lead is podcast number 2. why physicians must lead. I'll lay out characteristics of physicians that position us to lead. I'll debunk the myths around physician leadership and spell out the evidence about outcomes when physicians are in charge of hospitals and healthcare systems. Podcast number 3 is about the masters who currently lead healthcare. What do we know about MHAs and MBAs, Masters in Healthcare Administration and Masters in Business Administration? And then number 4 is titled Burnout, Autonomy, Neuroscience, and the Medical Profession. In podcast episode number 5, I'll respond to comments and feedback before launching into my 2020 License to Lead curriculum for physicians and others in healthcare and outside of healthcare. Well, you'll see what I mean. I hope you've enjoyed this. I forgive you if you listen to this on 1.5 speed. Actually, I applaud you. I know you're busy. Thank you for listening at any speed. And above all, despite the crazy-making barriers you might face, thank you for all your care and caring. To learn more about how we work with physicians and other leaders to create healthy work cultures, or to join in the conversation for future podcasts, go to license2leadpodcast.com, where you can send me an email or leave me a voice message.